And then this morning, Maggie and I will be reviewing oral chemotherapy agents that are used in heme malignancies and stem cell transplant. And we've got quite a bit of material to cover, so I'll just jump right in. So today we'll review classes of chemotherapy agents, including their indications and mechanisms of action. We'll also review key adverse events for each class and agents, as well as compare side effects between agents within the same class. And then finally, we'll talk about important interactions, dosing, and administration pearls. For the first part of this presentation, we'll focus on targeted oral chemotherapy agents used in CML, myelofibrosis, GVHD, AML, and APML. So we'll start with BCR-ABL inhibitors. So many of you are familiar with Gleevec. So Gleevec is one of the first targeted oral chemotherapies in cancer in general, and it was approved in 2001 for CML. And Gleevec sort of paved the way for other targeted oral chemotherapy agents to come to market. Gleevec is a BCR-ABL inhibitor. BCR-ABL is a fusion protein that results from chromosomal translocation between chromosomes 9 and 22, and this is also known as the Philadelphia chromosome. And this results in a constitutively active tyrosine kinase, which leads to uncontrolled cell growth. BCR-ABL is most commonly associated with CML and is a hallmark of CML, but can also be seen in ALL, so that's what we term as pH-positive ALL. And then you may also see BCR-ABL in other malignancies. We often think about BCR-ABL inhibitors in terms of their generation. So imatinib is going to be your first generation TKI, dasatinib, nilotinib, and bosutinib will be your second generation agents, and then ponatinib will be the third generation agent. In terms of dosing, these are all once daily, except for nilotinib, which is a twice daily medication. That's important to keep in mind when you're thinking about adherence, which we'll talk about in this presentation. But knowing that people are going to be on this medication for many years, it is definitely worth considering. I will comment that with nilotinib, the first dose reduction actually does drop the dose frequency to once daily. It would be 400 milligrams once daily. For renal dose adjustment, imatinib and bosutinib are going to be the two agents that would require upfront renal dose adjustment. All of the TKIs are metabolized hepatically by CYP3A4, but dasatinib is the only one that does not require upfront dose reduction for hepatic dysfunction. And then imatinib and nilotinib are going to be your agents that are both 3A4 inhibitors and substrates. In terms of food interactions, ponatinib is the only one that can be taken without regard to food. Imatinib and dasatinib don't have to be taken with food, but typically we do recommend that they do for GI tolerance reasons. Bosutinib should be taken with food to aid in drug absorption. And then nilotinib is going to be the only agent here that has to be taken on an empty stomach. So again, something worth considering, knowing that this is a twice daily medication. When I think about this drug class, I do think about antacid interactions. They're worth calling out given that the second generation TKIs are preferred first-line agents. So second generation TKIs do rely on an acidic environment for drug absorption. For dasatinib, both H2RAs and PPIs should be avoided entirely, and this would actually be called out as a category X interaction. TUMS could be used as needed if it can be separated by at least a couple of hours from dasatinib. Nilotinib and bosutinib are also impacted by H2RAs and PPIs. Prescribing information will say that you can separate antacids from the TKI, but if possible, we should still try to avoid, knowing that there's data to show that there's still an impact on drug absorption. And this can be a challenging interaction to navigate since some patients do require being on an H2RA or PPI. It's not an absolute contraindication. We do have some strategies for managing patients on this concurrent therapy. All right, so as a class, BCR-ABL inhibitors can cause bone marrow suppression and rash. Each agent also has a unique side effect profile due to off-target effects, and then we'll review that here on this slide. So starting with imatinib, really most of these agents can cause some sort of fluid retention, but just in different fashions. With imatinib, fluid retention can present as periorbital edema, so patients may have swelling under the eye, and sometimes this can even lead to blurred vision. Imatinib has the most tendency to cause nausea, so again, that's why it's recommended to be taken with food. And then rash and musculoskeletal pain are also some of the more unique side effects of imatinib specifically. For dasatinib, fluid retention can present in the form of pleural and pericardial effusions. Dasatinib can also cause pulmonary arterial hypertension and also thrombocytopenia, and sometimes this can be significant enough where a change in the TKI is warranted. For nilotinib, you can think of that as your major QTc prolonging agent within this class. It is recommended to get a baseline EKG at baseline and then also 1 week after initiation and then periodically thereafter. The package insert for nilotinib does have some recommendations for dose reductions depending on the, or management of the medication depending on QTc elevation. Other cardiac toxicities unique to nilotinib would be peripheral arterial occlusive disease, and then also there is a risk for pancreatitis and metabolic syndrome. Bosutinib is the newer second-generation agent. It also has a risk for fluid retention, both pleural and pericardial effusion, but as well as peripheral edema. It does have also a warning for hepatotoxicity and GI toxicity, particularly diarrhea. So that's kind of one of the first things I think about when I think about bosutinib. And then ponatinib, as a reminder, is our third-generation agent and probably has one of the more potentially serious toxicities. There is a boxed warning for ischemic reactions, arterial occlusive events, and hepatotoxicity. I think it's worth mentioning that at UW, we do have a statin built into our ponatinib-containing plans for cardiovascular risk reduction. Although it's not a package insert recommendation, we have included that in our plans. Hypertension is also another side effect with a fairly high reported incidence of about 30 to 50%. And then ponatinib also has the potential to cause pancreatitis, so we are monitoring lipase with this agent. I also think it's worth mentioning that to limit toxicity risks, there are dosing recommendations to reduce the ponatinib dose in pH-positive ALL if patients achieved MRD negative CR, and also in CML chronic phase if the BCR-ABL transcript is less than 1%. So you may see dose reductions if patients are in that bucket. I kind of mentioned this before, but adherence with these CML TKIs is really important. And there's a lot of data linking adherence to clinical outcomes in CML. There's data showing that non-adherence to imatinib contributes to cytogenetic relapse and poorer responses. Adherence is traditionally defined as taking a medication 80 to 85% of the time. So to put that into perspective, that means up to 4 missed doses per month or 1 missed dose per week. So it's really not a ton of wiggle room for missing doses with CML if you're being considered adherent. Lower adherence has been associated with a younger patient age, adverse effects, and so managing adverse effects on these TKIs is very important. Dose escalation linking to adverse effects, and then also high copays. I will mention that imatinib is available at a relatively affordable cost through Mark Cuban Pharmacy, and so for that reason, you may see patients on imatinib, even if it's not going to be the preferred first-line agent. One of the newer CML agents is asciminib. I also think it's the most difficult one to say. Asciminib is a STAMP inhibitor. So all of the other BCR-ABL inhibitors bind to the ATP binding site, which leads to competitive inhibition of the protein, whereas asciminib binds to this myristoyl pocket of BCR-ABL, and that leads to allosteric inhibition of the protein. Asciminib is indicated in pH-positive CML in the chronic phase after 2 or more TKIs, and the dosing is either 80 milligrams once a day or 40 milligrams twice a day. It's also indicated in pH-positive CML in chronic phase with this T315I mutation. And then it's worth noting that this dose with this particular mutation is much higher. It's 200 milligrams twice a day. Asciminib should be taken on an empty stomach. It's also hepatically metabolized, but it is a weak CYP3A4 inhibitor, so drug interactions are not as significant with this agent typically. There was a phase 3 trial published in New England Journal of Medicine this year where asciminib was compared to investigators' choice TKI, and data showed both superior efficacy with asciminib compared to the other TKIs and a more favorable side effect profile. And those side effect profiles from that trial are showed here. I think the side effects worth mentioning with asciminib would be the hematologic side effects, so thrombocytopenia, neutropenia, and leukopenia. I think it's important to keep in mind that the side effects can be dose dependent. So if someone's receiving that 200 milligram twice a day dose, you may see some of the more other side effects with this drug, such as myalgias, fatigue, and diarrhea. So here at our first assessment question, QR is a 27-year-old male who started nilotinib as first-line therapy for CML. It's noted he's noted to have a suboptimal response to therapy on BCR-ABL testing. Which of the following may contribute to his suboptimal response? So you can throw it in the chat. Is it A, concomitant carbamazepine use, B, lansoprazole as needed use for heartburn, C, occasionally missing evening doses, D, taking with food, or E, all of the above? And I'll give you guys a moment to put in your thoughts. Awesome. I'm seeing everyone saying E. That is correct. So keep in mind, a lot of our anti-seizure medications are CYP inducers outside of Keppra. So if someone's on an anti-epileptic, it's important to make sure that we're catching and managing those interactions. PPIs can impact the absorption of nilotinib. C is related to non-adherence, and then D, as a reminder, nilotinib should be taken on an empty stomach. So E is the correct answer. So moving on to JAK inhibitors. So our agents within this class are going to be ruxolitinib, fedratinib, pacritinib, and then the newer agent, momelotinib. Starting with ruxolitinib, it was the first approved JAK inhibitor and inhibits Janus-associated kinase, both JAK1 and JAK2. The JAK-STAT pathway leads to expression of cytokines and gene expression, which are important in hematopoiesis and immune function. Ruxolitinib is hepatically metabolized by CYP3A4, and it does require upfront renal dose adjustments using what I would consider maybe a little bit higher creatinine clearance cutoff of 60. There are multiple approved indications for ruxolitinib, so intermediate to high-risk myelofibrosis, polycythemia vera, and then probably where we see it more commonly is going to be steroid refractory acute GVHD, and then also chronic GVHD after failing 1 to 2 previous lines of therapy. So fedratinib and pacritinib, and I should have added here momelotinib. Fedratinib and pacritinib are JAK2 selective agents, and then momelotinib is JAK1 and JAK2. All three of these agents are approved in intermediate to high-risk myelofibrosis. I do want to call out that pacritinib is approved in this indication for patients with a platelet of below 50, and then momelotinib has been approved in this indication for patients with anemia. I think it's worth mentioning because that can drive some of the insurance approvals if patients are not exactly meeting this indication. Pacritinib is the only agent here that is dosed twice daily. The other two are dosed once daily. They are all hepatically metabolized. Fedratinib and pacritinib are your CYP3A4 agents, and then momelotinib is metabolized by multiple CYP enzymes. I want to call out that with momelotinib, 40% of the pharmacologic activity does come from the active metabolite as well. Some of the more unique side effects or warnings worth calling out. So with fedratinib, there is a risk for Wernicke's encephalopathy. And so we do check and replete thiamine prior to starting this agent. With pacritinib, there is a warning for hemorrhage and QT prolongation. With momelotinib, infection and hepatotoxicity. The package insert does specify with infection that patients should have an active infection resolved before starting therapy. And then all three of these agents do carry a warning for major adverse cardiovascular events. So that's important to consider when starting a patient on one of these agents. Thinking about side effect profiles, so within and these are grade 3 and above for these hematologic toxicities. For anemia, it's been reported more with a ruxolitinib. Obviously, with momelotinib, it's indicated in patients with anemia, so it wasn't reported in the package insert, any incidents. With thrombocytopenia, there's a high reported incidence with pacritinib, but it's worth calling out that in the trial with pacritinib, they enrolled patients with platelets less than 50, so some of that can be skewed for that reason. And then a little bit higher incidence of neutropenia with a ruxolitinib. Thinking about GI toxicity, so ruxolitinib is going to be, in general, more well tolerated from a GI perspective. Oh, there we go. With fedratinib, with more propensity to cause diarrhea and nausea. And then ruxolitinib can cause weight gain, so that's something important to keep in mind, especially knowing that patients can be on this for a period of time if they're using it for GVHD as well. Moving on to our FLT3 inhibitors, we have midostaurin, gilteritinib, and quizartinib. For completeness, I want to call out that sorafenib is also has FLT3 activity, but it's not used in hematologic malignancies, so it's not going to be covered in this presentation. So FMS-like tyrosine kinase 3 or FLT3 receptor serves as an important role in hematopoietic survival and proliferation. There's two types of mutations, the internal tandem duplication region or the ITD mutations, and then your tyrosine kinase domain mutations or TKD mutations. We can also classify these as first-gen and second-gen inhibitors. So first generation is going to be sorafenib and midostaurin. These are more non-specific, and they'll hit other receptors as well. And then your second-generation agents are going to be gilteritinib and quizartinib. These are more potent and selective for FLT3. The type 1 inhibitors are going to inhibit both ITD and TKD. So this is going to be midostaurin and gilteritinib. And then your type 2 inhibitors are going to be sorafenib, quizartinib, and ponatinib. And they're not effective against the TKD subtype. So something to consider if you're thinking about starting quizartinib, the patient has to have an ITD mutation and can't have just the TKD subtype. For quizartinib, all three of these agents are indicated in AML. Midostaurin is indicated in newly diagnosed AML in induction and consolidation. Quizartinib is indicated in FLT3 ITD AML in combination with 7+3 in induction, your consolidation, and also in post-consolidation maintenance. And then gilteritinib is indicated in relapsed and refractory AML. I do want to call out that we're seeing more use of gilteritinib in the post-stem cell transplant setting as maintenance therapy. There is more recent data to show that there is a higher relapse-free survival compared to placebo, especially in patients with detectable FLT3 MRD pre or post-transplant. So we do have some patients on this in the maintenance setting after transplant. And then midostaurin is also indicated in mast cell leukemia and systemic mastocytosis. Midostaurin is a twice-daily medication, whereas the rest of these are once daily. All three of these agents are metabolized by CYP3A4. With midostaurin, nausea and diarrhea, or especially nausea, is a major consideration for side effects. So we do pre-medicate, or patients do pre-medicate with Zofran prior to their doses. With quizartinib, and there is also a risk for nausea and diarrhea and transaminitis, similar to gilteritinib, although the transaminitis risk with gilteritinib is higher. All three of these agents do have potential to cause QTc prolongation, with quizartinib having a much higher or significant risk for that. There is also a REMS program for QTc prolongation management. That's kind of a call out with the quizartinib. Moving on to IDH inhibitors, so our agents will be enasidenib, ivosidenib, and the newer agent olutasidenib. There is a relatively newly approved IDH inhibitor called vorasidenib, although that's currently approved for use in CNS malignancies, so I'm not going to cover that in this presentation. So IDH is isocitrate dehydrogenase. The mutant variety results in inability of cells to differentiate and then leads to accumulation of leukemic blasts. There are two isoforms, IDH1 and IDH2, and they function in different parts of the cells. Ivosidenib and olutasidenib are going to be your IDH1 inhibitors, and then enasidenib is going to be your IDH2 inhibitor. Ivosidenib's approved in newly diagnosed and relapse refractory AML, whereas olutasidenib currently is approved in the relapse or refractory setting, similar with enasidenib. Olutasidenib is the only twice-daily medication and has to be taken on an empty stomach, so somewhat similar to nilotinib dosing and administration. These are also hepatically metabolized. There is a risk for nausea with these agents. The side effect that comes to mind whenever I think about an IDH inhibitor is differentiation syndrome, which we'll talk about on the next slide. And I think the other thing worth calling out is the risk for elevated T-billing with enasidenib, quite high reported incidence at 81%. QTc prolongation is a warning similar to differentiation syndrome. Differentiation syndrome occurs due to rapid proliferation and differentiation of these myeloid cells. Symptoms of this include dyspnea, pulmonary infiltrates, pleural effusions, renal impairment, fever, edema with rapid weight gain. The onset of this can be even months after starting these agents. So even, it's been reported up to 5 months after starting. And treatment for differentiation syndrome is Dex 10 every 12 hours until symptom resolution. And then moving on to our final class of agents, which will be your retinoic acid derivative. Tretinoin is the only agent within this class. So tretinoin, or also known as all-trans retinoic acid, or ATRA, if you've ever heard that acronym before. It is used in acute promyelocytic leukemia, and it is a differentiating agent similar to our IDH inhibitor. The dosing for this in APML is 22.5 mg per meter squared BID. What I want to call out is that these are only available as 10 milligram capsules, and so somebody may, depending on their BSA, they could have quite a few pills to be taking twice a day, and so just keep in mind that this does add to the pill burden in APML. And then it is hepatically metabolized, but does not require any upfront renal or hepatic dose adjustments. Thinking about side effects, so again, differentiation syndrome is going to be something that we're monitoring for. Unlike the IDH inhibitors, the onset can be more quick after starting therapy. So we actually do give prednisone prophylaxis for differentiation syndrome. And then treatment is very similar. Again, dexamethasone every 12 hours until symptom resolution. ATRA can also increase cholesterol and triglycerides, so it's not, I guess, uncommon for people to need medications for management if they're on ATRA, and then also LFT abnormalities are something we're thinking about. So the tricky thing with tretinoin toxicities is that tretinoin is the only agent within this class, and there's no alternative. And knowing that APML is such a highly curable disease, we really want to do what we can to manage side effects and keep people on therapy. So that's what I had for you guys with these agents, and then I'll turn it over to Maggie to give the second half of the presentation, and then we'll just save questions for the end just to make sure we can get through all the material.
Thanks, Harpreet. Can everyone see my screen here? Good, see some head nods. All right. Well, my name's Maggie. I'm one of the hematology clinic pharmacists, mostly working with lymphomas and myelomas. And I'm going to be presenting part 2 of the lecture today on the hematology oral agents. So the classes that I'll cover today are immunomodulatory agents, BTK inhibitors, PI3K inhibitors, our BCL2 inhibitor, venetoclax, and then our nuclear export inhibitor, selinexor. So first up, immunomodulatory agents. This includes lenalidomide, pomalidomide, and thalidomide. So we can't talk about the IMiD class without first touching a bit on the history of thalidomide first hitting the market, because as some of you may know, it was kind of an exciting time. This history plays an important role in the education and monitoring that we do today via the REMS program for all of the IMiDs, which we'll talk about shortly. So thalidomide was first marketed in Germany in the late 1950s as a sleep aid, and it was shortly thereafter used in the treatment of morning sickness in pregnant women. Within a few years, its use became widespread across Europe, Australia, and Japan. And around 10,000 babies were born with a condition called phocomelia, which is pictured here in this slide. It's a condition of shortened, absent, or flipper-like limbs. And it was not until 1961 that a physician associated the drug with these birth defects, and then it was then subsequently banned in many countries. So this tragedy was largely avoided in the US because of the FDA inspector, Frances Kelly, at the time. She held up the approval of thalidomide in the US because she didn't feel comfortable approving it due to the lack of data in the pregnant population. She also had concerns for its side effect of peripheral neuropathy that was being associated with it. President Kennedy then awarded her with the Gold Medal Award for Distinguished Civilian Service because she really held her ground despite the pressure to approve it in the US. This tragedy also led to the Kefauver-Harris drug amendment, which required drugs to be proven both safe and effective prior to marketing. So then fast forward in time, in the late 1990s, thalidomide re-enters the market for the treatment of myeloma and leprosy. So REM stands for Risk Evaluation and Mitigation Strategy. This program applies to, in the IMID class, all three of them, thalidomide, lenalidomide, and pomalidomide. The goals are to prevent the risk of embryo-fetal exposure to patients on IMIDs, and then inform prescribers, patients, and pharmacists on the serious risks and safe use conditions. So only certified prescribers and pharmacy can write prescriptions for it and fill this. There are lots of steps that each of the players in this process have to take in order to fill just a single prescription for this. So if you're a prescriber, you have to obtain an authorization number for each prescription. Oftentimes in clinical practice, this is like a designated representative of the prescriber. So like the clinic nurse is often doing it at our clinics. This auth number has to be listed on the prescription. Then you also have to list the patient's reproductive risk category. So for example, it would actually say like non-reproductive female or male. That goes on every single prescription. For females of reproductive potential, you have to verify a negative pregnancy test for all fills. A prescription can only be written for a maximum of a 28-day supply, and you cannot put refills on it. Patients have to complete a confidential survey prior to filling the medication. They can do that online or via phone. And then reproductive females have to use 2 effective forms of birth control. And then prior to dispensing this, the pharmacy has to obtain a confirmation number for each prescription and complete an education counseling checklist for each dispense. So as far as the mechanism of action goes, it's multimodal and not totally understood. We know that there's some direct cytotoxicity and apoptosis on cancer cells, inhibition of interleukin-6 and decreased myeloma cell adhesion, some decreased angiogenesis to the tumor cells, and then enhanced T cell cytokine production and natural killer cell mediated cytotoxicity. So structurally, all of the IMIDs are very similar to one another. However, clinically, there are some key differences in how we use them, as well as some pharmacokinetic and pharmacodynamic effects. So you'll see here thalidomide is, indicated in multiple myeloma and leprosy. Typical dosing is 50 to 200 milligrams by mouth daily, and it is eliminated via hydrolysis, so non-renal and non-hepatic. Lenalidomide is indicated in multiple myeloma and non-Hodgkin's lymphoma and MDS. Typical dosing is 5 to 25 milligrams, and the most common dosing schedule is 3 weeks on, 1 week off, or another way to say that, days 1 through 21, every 28 days. Lenalidomide undergoes renal elimination, so you do have to dose reduce for decreased creatinine clearance. And then pomalidomide finally is indicated in multiple myeloma and Kaposi sarcoma. Dosing is typically 1 to 4 milligrams, again on that 3 week on, 1 week off schedule. And this one undergoes hepatic metabolism. There are some class side effects of the immunomodulatory agents that you should think about whenever you think of these medications. So embryo-fetal toxicity, we already discussed. Blood clots, so there's a risk of VTE, MI, and stroke. So therefore you have to provide thromboprophylaxis for all patients. Most common agent that we use is a full-strength aspirin once daily. All of these agents can cause rash, and they can all cause infection. On the right-hand side here, you'll see some agent-specific side effects. So you'll see that thalidomide is associated with dose-limiting neuropathy and significant fatigue. This should make sense because when it first hit the market, it was being used as a sleep aid. Myelosuppression is a dose-limiting for lenalidomide and pomalidomide, which again kind of leads to that dosing schema of taking it for 3 weeks on, 1 week off to give the bone marrow some time to recover. Lenalidomide is both renally eliminated and can be nephrotoxic, so you do have to use caution in patients with renal impairment. And then secondary malignancies is most commonly associated with lenalidomide. It's mostly AML, MDS, but there are some solid tumors associated with it. And then do keep in mind that this does depend on the setting and other agents that patients may be exposed to. For example, patients who are eligible for an auto transplant and utilizing melphalan. So let's jump into our first patient case here. MS is a 67-year-old female with newly diagnosed multiple myeloma. Her treatment regimen you're planning to prescribe contains lenalidomide. She is not of childbearing potential, and her creatinine clearance is 40 milliliters per minute. Which of the following statements regarding lenalidomide is incorrect? All right, I'm seeing some answers come through the chat. Lots of B's, which I agree with. So we already discussed that the maximum amount or day supply you can prescribe a patient is a 28-day supply, no refills. All of the other statements in this case would be true. Next, we'll jump into our Bruton's tyrosine kinase inhibitors, ibrutinib, acalabrutinib, and zanubrutinib and pirtobrutinib. So Bruton's tyrosine kinase, or BTK, is integral to B-cell receptor signaling. And it's specifically a downstream signaling kinase that's upregulated in B-cell malignancies. And all these BTK inhibitors are oral small molecule inhibitors of that pathway. So this table here, you'll see a little bit of the differences between the agents from a pharmacokinetic standpoint. So our first generation BTK inhibitor is ibrutinib. It's a covalent irreversible inhibitor. It's got moderate selectivity for the kinase. And you'll see of all of the agents, it's got the most off-target receptors that it hits, which leads to its generally less desirable toxicity profile. Acalabrutinib and zanubrutinib are our second generation BTK inhibitors. They're both covalent irreversible binders of BTK. You'll see acalabrutinib is highly selective, whereas zanubrutinib is moderately. And then our last agent, pirtobrutinib, this is our third generation BTK inhibitor. It is a reversible inhibitor of BTK. It binds to the ATP pocket in a different manner than the other three that allows it to be effective for both wild type BTK proteins and those with a mutation called BTK-C481, which is the most common mutation known to date in CLL patients that can occur after being exposed to a covalent BTK inhibitor. This table here shows our FDA approved indications for these agents. You might see some of them being used off-label. Ibrutinib is indicated in CLL, Waldenstrom's, and then has an indication for chronic graft versus host disease. It used to be indicated in mantle cell and marginal zone lymphomas in the second-line setting, but that FDA labeling was pulled in April of 2023 just because of some inconsistent PFS benefits in some phase 3 studies. Acalabrutinib is indicated in CLL and second-line mantle cell lymphoma, zanubrutinib in frontline CLL, second-line mantle cell and marginal zone lymphoma, and then in Waldenstrom's. And then pirtobrutinib, lastly, is approved in the third-line setting for both CLL and mantle cell lymphoma. This table here shows some different dosing considerations and when you may need to dose adjust. So ibrutinib, the indication or the dosing is based on indication, so just be aware of that. It's a once daily medication that needs to be adjusted for mild hepatic impairment. Acalabrutinib is our only medication that must be taken twice daily. You want to avoid it in severe hepatic impairment. Zanubrutinib can be dosed once or twice daily. You need to dose adjust it for severe hepatic impairment. And then pirtobrutinib is 200 milligrams once daily. It's the only one with renal dose adjustments and no hepatic dose adjustments. You'll see here that all of these medications are cleared via the CYP3A4 metabolic pathway, which makes them all very prone to drug interactions. So even modern inhibitors that would be like diltiazem, verapamil, fluconazole may require some empiric dose adjustments. So just always double check on that if your patient is on one of these medications. So this slide here shows some of the adverse effects of interest for BTK inhibitors. Not shown are infection and myelosuppression, which can occur with all the BTKs. Adverse effects rates listed here are not from head-to-head trials, so just keep that in mind when comparing between agents. In general, we consider ibrutinib to have the most side effects due to those off-target effects, while pirtobrutinib appears to have the best tolerability that we've seen so far from the phase 1-2 studies. So ibrutinib typically has the highest rates of AFib and bleeding due to its non-selective inhibition of those TEC kinases. Its higher rate of rash and diarrhea are thought to be due to its off-target inhibition of EGFR. And then the other notable side effect is acalabrutinib, you'll see, is the highest rates of headache amongst any of the BTK inhibitors. So the next two slides here actually show some adverse effects, head-to-head comparisons from head-to-head trials between our first and second generation BTK inhibitors. And these are nice because we can actually get true comparisons of tolerability between the agents as well as efficacy. So this study here is the Elevate-RR study. It was a non-inferiority trial comparing acalabrutinib to ibrutinib in patients with previously treated CLL. So you'll see in general, ibrutinib has higher rates of grade 3 or higher adverse effects. Acalabrutinib does have a little more grade 3 or higher AFib, but all grade AFib was higher in ibrutinib. And then, as I had mentioned before, headache is more common with acalabrutinib than the other agents. This slide here shows the Alpine study toxicity data. This was a phase 3 trial comparing zanubrutinib to ibrutinib, again in patients with relapsed refractory CLL. Zanubrutinib demonstrated improved progression-free survival in this trial. And it also had fewer discontinuations due to adverse effects and fewer cardiac adverse drug events leading to treatment discontinuation or death. So again, kind of another reason we're using these second generations over ibrutinib in this setting. You will see that there's a little more grade 3 or higher hypertension in zanubrutinib, but again, all cardiac adverse effects are worse with ibrutinib. All right, and then the last thing to mention with BTK inhibitors that I think is really important is this phenomenon called redistribution lymphocytosis. And this can be unnerving if you're not aware of it because it is not disease progression, but you will see a transient absolute lymphocyte count increase in most of our patients. So this happens because there's inhibition of a chemokine receptor that results in trafficking of the CLL cells from the lymph nodes into the peripheral blood. This is not associated with relapse or toxicity, and it can happen pretty quickly upon initiation. It can last days to weeks and sometimes even months in people. Our next few slides are we're going to go over our BCL2 inhibitor, venetoclax. So venetoclax inhibits BCL2, which is an anti-apoptotic protein resulting in cell death. Its FDA-approved indications include CLL. You can use it as monotherapy or in conjunction with an anti-CD20 monoclonal antibody. And then in AML, for patients who are unable to tolerate intensive chemo, you can use it in conjunction with azacitidine, decitabine, or low-dose cytarabine. We commonly do see these off-label as well Common indications there would be your multiple myeloma patients with translocation 11-14 in the relapse refractory setting or in relapse refractory mantle cell lymphoma. So the dosing of venetoclax depends on the indication that you're using it in. So something to be very cognizant of as you're getting familiar with the medication. Tumor lysis syndrome risk is the highest with CLL. So you'll see here that the ramp up is done very slowly over the course of 5 weeks. AML, on the other hand, it's a little less of a concern. There is still a ramp up that we may do in patients. It's typically over the course of 3 to 4 days. As far as administration goes, this medication needs to be taken with a meal and a full glass of water. It undergoes hepatic CYP3A4 metabolism, which makes it highly susceptible to drug interactions. You need to avoid grapefruit juice while you're on this medicine. And then another key point with that is that our azole antifungal medications are pretty much all moderate to severe CYP3A4 inhibitors. So the venetoclax dose is empirically adjusted for that. Super important for our AML patients who have prolonged neutropenia and are typically started on an azole antifungal with this medication. So as far as adverse effects of venetoclax goes, these are a few ones I typically think of. Myelosuppression is a big one. You'll see with CLL, neutropenia and thrombocytopenia are quite common, but febrile neutropenia rates are actually pretty low. Whereas AML, you are going to be at higher risk for febrile neutropenia. These patients are typically neutropenic for a lot longer. This medication can cause diarrhea. Again, typically pretty manageable and low grade for most people. And then hyperuricemia, that kind of speaks to the tumor lysis syndrome component that is most commonly seen in CLL. So let's talk a little bit about tumor lysis syndrome prevention and monitoring with venetoclax, and I'm going to talk about CLL specifically because that's the condition where we worry about it the most. So you already saw it requires a slow dose ramp up. The standard of care ramp up is over the course of 5 weeks. Patients are risk stratified based on tumor burden and comorbidities, specifically their renal function. So you'll see on the right-hand side here, this table is pulled right out of the package insert. You're looking at their at lymph node size and absolute lymphocyte count. All patients are going to receive allopurinol for about at least 72 hours prior to venetoclax initiation, ideally. They all need to maintain good hydration, which means 64 ounces of fluid orally per day, plus or minus some IV fluids. And then you can even consider rasburicase in our high-risk patients in this setting. So for our low to medium risk patients, these patients can initiate their ramp up and be monitored in the outpatient setting typically. So just because it's outpatient though, they're still going to be at the clinic a lot as they're getting started here. So these patients, for their first 2 dose escalations, so the 20 and 50 milligram dose initiations, they have to get labs at baseline, 6 to 8 hours post-dose, and 24 hours post-dose, and then pre-labs for remaining escalations. For high-risk patients, these patients are actually admitted to the hospital for the first 2 dose initiations. They get labs drawn at baseline, then at 4, 8, 12, and 24 hours after the first dose. So typically the admission is a little over 24 hours if all is going well and they're not experiencing tumor lysis syndrome. And then their outpatient labs kind of mimic those initial monitoring recommendations for the subsequent dose escalations, baseline 6 to 8 hours post-dose and 24 hours post-dose. So this is a lot to keep straight. Our beacon treatment plans that we have here actually do correlate to these monitoring and prevention recommendations for both these scenarios. So you'll see like, you know, the venetoclax, whatever medication, if you're using it in conjunction with it, and then whether it's low to medium or high risk patients, and they'll actually have the appropriate labs and medication orders that you need in there. So patient case number 2, DL is a 64-year-old male with newly diagnosed CLL. He does not want to come in for frequent lab monitoring required for venetoclax, so you want to prescribe him a BTK inhibitor. He's got a past medical history of a PE, hypertension, headaches, and diabetes. Current medications include apixaban, amlodipine, naproxen is needed for headache, and metformin. Which BTK inhibitor would you like to prescribe for DL? There's not a perfect answer in this scenario, I will say. Go ahead and throw your answer in the chat. Great. I'm seeing lots of C's come through. I would agree. To kind of walk through this thought process here, ibrutinib is just less desirable because of the side effect profile. And for DL, we're really concerned about the additive bleed risk with apixaban. Again, not a complete contraindication, but we certainly have better options. Acalabrutinib is certainly reasonable, but with headaches occurring in up to 40% of patients, I think we can avoid this trouble. We don't want them taking NSAIDs while he's on a BTK inhibitor, ideally, nor the apixaban. And then pirtobrutinib is just not currently indicated in the frontline setting. So that one is ruled out pretty easily. Nice job. Our PI3 kinase inhibitors, adalimumab, duvelisib, and alpelisib. So you used to have more slides on these, but in the I'll explain soon. This medication class is kind of falling out of favor in some of the CLL and B-cell malignancy treatments or lymphoma treatments. Adalimumab and duvelisib are both currently FDA approved for relapsed CLL. They're both oral twice daily medications. Alpelisib is actually indicated in the advanced breast cancer setting. I won't talk more about that today. That one is a pretty commonly used medication, and it's an oral medicine taken once daily. So over the last couple of years, we've seen a shrinking indication list for our PI3 kinase inhibitors in hematologic malignancies. And a lot of that is just because of the high degree of adverse effects that were occurring with these agents, and the FDA requiring more confirmatory studies around these agents as they thought necessary for safety purposes. So duvelisib had a removal of follicular lymphoma indication. This was a voluntary removal by the manufacturer because they didn't, again, want to put in the resources required into confirmatory studies. Adalimumab had a removal of follicular lymphoma and SLL indications for the same reason. Umbralisib was a medication that was totally removed from the market because of the settings that it was indicated in. There were some updated trial findings that showed a possible increased risk of death with this agent. And then copanlisib was an IV PI3 kinase inhibitor that was removed for the indication of follicular lymphoma, which was its only FDA-approved indication. And again, the confirmatory trial didn't meet the primary progression-free survival primary endpoint. So this slide here just shows kind of some of the hallmark adverse effects that are associated with one of the currently approved PI3 kinase inhibitors out there today, adalimumab. And what you'll see is there are really high rates of serious adverse effects of these agents, so you have to use caution if and when you're utilizing them. Up to 16% of patients had serious or fatal hepatotoxicity. 20% of patients with grade 3 or higher diarrhea or colitis. So the lower grade diarrhea, you can use antidiarrheal agents, but when it gets to be higher grade, you're actually using things like steroids. Pneumonitis risk is about 4%. Up to 48% of patients will have fatal or serious infections. That includes CMV reactivation and PJP pneumonia. So PJP prophylaxis is required with adalimumab. High rates of neutropenia, and then high rates of serious skin reactions. And the last agent here we'll talk about is our nuclear export inhibitor, selinexor. So XPO1 is a nuclear transport protein that's overexpressed in cancer cells. Its main purpose in the cell is for transporting growth regulators and oncoprotein mRNA out of the nucleus and into the cytoplasm. Selinexor inhibits XPO1, so it can't carry these proteins out of the nucleus, and this leads to accumulation and eventual cellular apoptosis. Selinexor is FDA approved in the relapse refractory setting of both DLBCL and multiple myeloma. The dosing is something to be aware of. It's a medication that's taken once or twice weekly. So that's an important counseling point for patient. These are not daily medications, once or twice weekly. And then you may see them used as monotherapy or in conjunction with other therapies, especially in the myeloma setting. What I will say in our multiple myeloma setting is that we are typically using lower doses than what you will see in these FDA approved indications, and that's mostly for tolerability purposes. So selinexor does have a lot of adverse effects to be aware of and manage. In the trials, over 60% of patients had interruptions or dose adjustments due to toxicities. So thrombocytopenia and neutropenia are important ones to note. Bleeding occurred in 23% of patients in the trials. Again, so you see high rates of all grade and grade 3 to 4 thrombocytopenia. Neutropenia rates are quite high. Nausea is a side effect to be aware of. Patients do have to take scheduled antiemetics around their selinexor. So for our treatment plans here, we schedule ondansetron prior to each dose and for every 8 hours for 2 days following their selinexor dose. And then you'll typically want one other agent as well. A lot of these patients are on dexamethasone anyways for myeloma, but other options would include olanzapine or like an oral aprepitant. Hyponatremia is something to be aware of that can occur. And then neurologic toxicity as well. So what this can present as is dizziness, syncope, depressed level of consciousness, vertigo, amnesia, or mental status changes. So just something to be aware of and monitor patients for. All right, so now I'm going to wrap it up with just some conclusions around oral chemotherapy and the heme agents in general. So you want to use your drug classes and mechanisms of actions to kind of set a baseline knowledge for remembering toxicities and dosing strategies, while also being thoughtful to individual drug differences. You want to be aware of interacting medications, so kind of have your red flag drugs in mind. Ones that I think about that commonly interact with these oral chemotherapy agents are warfarin, anti-epileptics, antivirals for HIV/AIDS, azole antifungals, and antiarrhythmics. And then always double check if it's okay to use stomach acid suppression with oral oncolytic agents until you're familiar with them. For patients with renal or hepatic dysfunction, check the specific agent for dose modifications that might be necessary. So things like package inserts can be helpful for this, tertiary drug databases, and of course, primary literature and case reports if you need to. And then even though these medications are taken at home, most still do require frequent monitoring. So keep in mind, like that venetoclax for CLL, you know, they can be convenient options for patients, but to set appropriate expectations, oftentimes when you're getting started, there can still be a high degree of monitoring required. So with that, thank you all for attending this morning. We'd be happy to take questions or comments.
This is like a general question for, I guess, all like oral chemo meds, but is there like any good resources to know like when to hold around procedures and things like that?
I think the first place that I go is either like the package insert. Some of the newer-ish agents like BTK inhibitors are ones that I, do a lot with the bleeding risk. They actually have some recommendations in there, and those will pull into LexiComp as well. And then if you're not finding it there, just looking for trials, I would say. Harpreet, any other thoughts or ideas?
No, that's exactly what I would have done.
Okay, well, Danny gets best dressed today with the bow tie. Love that. Yeah, this is a great talk. Like the BCR able can express, like I think as an oral class that has the most diversity of AEs to deal with, and we see all of those. So you'll see them all throughout your fellowship. And then yeah, the PI3Ks have the highest percentage of grade 3 effects. So yeah, really enjoyed the talk, and thanks for the attention, everyone. I'll see you guys tomorrow. Have a great day.